Welcome to Discussion Lab 6, Antibody Detection in Medical Diagnosis. Today, we are examining the gap between a flawless biochemical reaction and a complex clinical reality. In a controlled laboratory setting, detecting a specific molecule is a straightforward triumph of biochemistry. We can engineer assays where a Y-shaped antibody perfectly locks onto a viral target with absolute mechanical precision. But translating that exact same molecular detection into a human diagnosis requires an entirely different skill set. You have to navigate statistical probabilities, patient history, and epidemiological context to interpret what that binding actually means. A positive laboratory result simply confirms the presence of a molecule. It does not automatically equal a clinical diagnosis. To understand why, we have to look at the timeline of an infection. The moment a pathogen enters the body, the immune system doesn't instantly flood the bloodstream with antibodies. This process takes time, and that delay is called seroconversion. This chart maps the typical immune response over a 30-day period. The first responders are IgM antibodies. They indicate an acute primary infection, peaking rapidly around days 7 to 10 before eventually dropping off. Following the initial wave, a second class of antibodies takes over. These are IgG antibodies. Their production is delayed, starting around day 14, but they remain elevated for months or even years, establishing long-term immunological memory. The diagnostic challenge lies in the earliest days of infection. This gap between day 0 and the first appearance of IgM is the window period. The patient is actively infected and potentially contagious, but their detectable antibody count is effectively 0. If you order a standard serological test during this specific time frame, you will get a false negative result. Failing to respect the physiological kinetics of the immune response invalidates even the most precise diagnostic assay. Because an antibody binding to an antigen is microscopic and invisible to the naked eye, we have to find a way to make that event measurable. We achieve this through engineered signal amplification. The physical foundation for this engineered signal amplification is the enzyme-linked immunosorbent assay, commonly known as the ELISA. This process usually takes place inside the tiny wells of a standard 96-well microtiter plate. In a sandwich ELISA, we start by anchoring a capture antibody to the plastic floor of the well. When we add the patient's serum, this anchored antibody traps the specific target antigen we are looking for. To prove that capture happened, we add a primary antibody that binds to the top of the antigen. Then we attach a secondary antibody. This secondary antibody is critical because it carries a payload, an enzyme like peroxidase. We have now built the sandwich. The final step is adding a chemical substrate. The enzyme oxidizes the substrate, triggering a visible color change. A spectrophotometer reads this color intensity, calculating the exact concentration of the targeted antibodies. Modern assays manipulate this architecture to shrink the window period. A fourth-generation HIV ELISA, for example, is designed to detect both the patient's IgM and IgG antibodies and the P24 viral antigen simultaneously. By looking for the physical virus alongside the immune response, the time it takes to detect an infection drops significantly. The utility of an ELISA is its ability to mathematically translate an invisible molecular binding event into macroscopic, actionable clinical data. Not all diagnostic readouts rely on colorimetry. Immunofluorescence swaps the enzyme for a light-emitting fluorophore. A fluorophore is a chemical compound that re-emits light upon excitation. This allows pathologists to physically see the target. Direct immunofluorescence, or IFD, applies these glowing antibodies directly to a physical tissue biopsy. This localizes specific bacterial or viral antigens right at the site of infection. Indirect immunofluorescence, or IFI, adds a step to detect circulating autoantibodies within a patient's blood serum. The patient's unlabeled primary antibody binds to a test cell, and our glowing secondary antibody binds to the primary, acting as a beacon. Where an ELISA yields a precise quantity, immunofluorescence yields a spatial map. The physician's readout shifts from a numerical concentration on a chart to a distinct physical pattern under a microscope. For decades, standard diagnostic algorithms followed a strict sequence. A highly sensitive screening ELISA was always verified by a highly specific confirmatory test to weed out false positives. The gold standard for this was the Western blot. The Western blot operates by physically dismantling the pathogen. Using a detergent to dissociate the viral proteins, they are dragged through a gel matrix using an electrical current, sorting them strictly by their molecular weight. These sorted proteins are transferred to a nitrocellulose strip. If the patient has antibodies for these specific proteins, they bind to the strip, creating a readable barcode-like banding pattern to confirm the diagnosis. However, clinical diagnostic guidelines are actively shifting. Based on modern blood bank data, organizations like the CDC and the World Health Organization are phasing out the Western blot. The test has critical operational flaws. It is highly complex, takes too much time to process, and frequently yields indeterminate, ambiguous results that leave patients without answers. The modern replacement relies on rapid recombinant immunoassays, like the Genius platform. These tests use specifically engineered viral peptides to deliver the high specificity of a Western blot, but at the speed of a rapid test. Clinical diagnostic validity is not static. Protocols must constantly adapt as new technologies mitigate the physical limitations of historical assays. The danger of reading lab results without clinical context becomes obvious when evaluating autoimmune diagnostics, specifically the anti-nuclear antibody, or ANA test, used to detect systemic lupus erythematosus. This chart represents a patient population. The ANA assay is extremely sensitive. Over 95% of patients with actual lupus will trigger a positive result. This extreme sensitivity makes it an excellent tool for exclusion. If a patient's ANA test is negative, you can confidently rule out lupus. But here is the epidemiological trap. Up to 15% of healthy individuals will also trigger a false positive ANA test. The mathematical reality is stark. Of all positive ANA reports, only 11 to 13% actually have lupus. Evaluating a highly sensitive screening test without factoring in the patient's actual clinical symptoms is a statistical trap. Sensitivity is not specificity. This defines the physician's ultimate role. You do not blindly treat the lab report. You apply pre-test probability to the assay's architecture. Let's bring this to the lab. Scenario 1, the window period. How do you manage a patient with acute symptoms returning a negative fourth-generation ELISA? Scenario 2, the predictive value. How do you manage a healthy 25-year-old presenting with an isolated positive ANA test at a 1 to 160 titer for fatigue? Scenario 3, the evolution of testing. Debate the epidemiological risks and benefits of public health sectors abandoning the Western blot for rapid recombinant assays. Analyze the epidemiological data, question the biochemical architecture of the assays, and treat the human patient.